Hi, everybody. My name is Pam Kunz, and I'm an associate professor of medicine in the section of oncology at Yale School of Medicine. And it's my pleasure to present a couple of cases to you tonight. So, case one is a 50-year-old woman with a functional, metastatic, well differentiated WHO grade 2 neuroendocrine tumor, and I'll use the abbreviation NET, of the terminal ileum with liver metastasis and progression on octreotide long-acting release. She is a functional NET because she has secretion of 5-HIAA, that's a metabolite of serotonin. So her oncology history is as follows. 14 months prior, she presented with bright red blood per rectum, flushing, and had no diarrhea. A colonoscopy in the course of the workup for these symptoms revealed a 5-centimeter mass in the cecum, and a biopsy showed a well-differentiated NET, WHO grade 2 with a Ki-67 of 6.5%. A CT abdomen with contrast showed a mass at the cecum with no liver lesions. And I'll make just a point here that it's important that CT scans be ordered as multiphasic or at least have arterial and venous phase imaging for neuroendocrine tumors. So the onc history continued. She then underwent a right hemicolectomy because of this 5-centimeter cecal mass. It showed a well-differentiated NET grade 2. The Ki-67 was 7.6%. It's actually quite common to have slight heterogeneity between the biopsy and a resection specimen. It showed a 3.5-centimeter tumor with tumor deposits present at the subserosa and serosa of the appendix. There was lymphovascular and perineural invasion present, and 8 of 36 lymph nodes were positive. So she was staged as a T4N1MX tumor following this resection. Unfortunately, a gallium-68 dotatate PET CT was done after her surgery and showed several radiotracer avid hepatic foci suspicious for liver metastases. And an MRI abdomen pelvis followed up on that and confirmed multiple bilobar liver lesions up to 1.9 centimeters. We also obtained a 24-hour urine 5-HIA. This was at 13.7 milligrams for 24 hours, and normal is less than 6. She was then started on octreotide LAR 30 milligrams and had really significant improvement in her flushing. So just to round out her history, she has a prior history of hypertension and anxiety, is married, has excellent social support, did not smoke tobacco or drink alcohol, and her medications at the time that this was going on were amlodipine, diazepam, and venlafaxine. So then she continued on octreotide, and then 15 months following that initial diagnosis and about a year after she'd been on octreotide, we'd been getting MRI abdomen pelvis every 3 months during that period of time. They were stable, and it was at this year mark after she'd been on octreotide that showed an increase in the size and number of the liver lesions. So this is really the key point that we're going to dive into a little bit further for this case. What's the most appropriate next step? And I wanted to just highlight, this is just one example. This is her MRI abdomen pelvis cross-sectional, looking at where the little yellow arrow is at one of the liver lesions. Her liver lesions are bilobar. They're scattered throughout the liver. So let's just take a big 30,000-foot view of what our treatment options are beyond somatostatin analogs. So for small bowel neuroendocrine tumors, for systemic therapy options, we have everolimus, lutetium dotatate for somatostatin receptor positive disease. Less frequently, we'll use cytotoxic chemotherapy. And then we have local regional therapies that include liver-directed therapies such as bland embolization, chemoembolization, and radioembolization. For pancreatic NETs, we have these same therapies. Everolimus, we also have sunitinib that's officially FDA approved for metastatic pancreatic NET. Capecitabine temozolomide, 2 cytotoxic chemotherapies are both oral. And we also have lutetium dotatate. And additionally, we have local regional therapies. And I think really we've had just so many advances in the last 10 to 15 years in neuroendocrine tumors. And so we have the good problem is now we have all these available therapies, but we don't know the optimal sequence. So we have yet to have head to head studies of active therapies to really help teach us which therapies to choose. I would say a very common first line treatment, which has happened for this patient, is somatostatin analog. However, the second line treatment is really what we're going to be talking about. So to continue for case one, this patient went on to receive lutetium dotatate. She received 4 standard cycles. Her treatment was well tolerated without significant side effects. She had a very slight decrease in her total white count by the time she completed the 4 cycles. So this is a picture after she received ludotate. You can see in the liver, scattered liver lesions. I'll remind our audience that some of these other areas of uptake are physiologic or normal. So in the pituitary gland, we see uptake. The spleen, we see normal physiologic uptake. And the GU system, the kidneys and the bladder, we're seeing those look bright because the lutetium dotatate is cleared through the GU system. So I'm going to go into a little bit of the background of why we would select a lutetium dotatate and where those data derive from. So the NETTER-1 clinical trial was a randomized phase 3 trial looking at the efficacy and safety of lutetium dotatate plus SSA compared to high-dose octreotide in mid-gut nets. So these are advanced nets. And patients were randomized 1-to-1 to receive 4 administrations of IV lutetium dotatate. That dose is 200 millicuries, and the comparator arm or the control arm was octreotide LAR at 60 milligrams. And so this is really very similar to this patient that we're talking about. So the primary endpoint of the clinical trial was progression-free survival. At the time this was published in New England Journal, primary progression-free survival had not been reached in the lutetium dotatate arm. That's in green. I'm looking at the figure on the left here. And was 8.4 months in the high-dose octreotide arm with a hazard ratio of 0.21. So a reduction, a sort of reduced hazard of progression by 79%. And so the p-value was statistically significant. Overall survival was not reached at the time that was initially reported. What I'd like to do is just update some of these data for you. So the final progression-free survival was 28.4 months in the lutetium dotatate arm versus 8.5 months in the octreotide arm. So really 2.5 years of progression-free survival. The secondary endpoint of OS was not met. It was 48 months in the lutetium dotatate arm versus 36 months in the control arm. And there were no new long-term safety signals. Again, this was, we still don't have many, many years, but the original publication was in 2018. That's when it was FDA approved. And we now, the Lancet Oncology update was in 2022. So that's 6 years of follow-up. I'd also like to highlight something that's really important. So what we see here in the red box, these are the response rates, is an 18% response rate in the lutetium dotatate group compared to 3% in the control group. So I'll remind you that somatostatin analogs have very low ability to shrink the tumor. So this is about a 20% shrinkage rate. So 1 in 5 patients on this study had some degree of, or had a significant degree of tumor shrinkage as defined by RECIST criteria. In terms of adverse events, the most common AEs were cytopenias, nausea, vomiting, and fatigue. I put in parentheses that one of the side effects that gets quoted a lot that's a serious side effect but rare is myelodysplastic syndrome, and that's still about a 2 to 3% risk, so quite low. I will say just broadly, most patients come back to me after receiving lutetium dotatate and say, "Doc, that was a lot easier than I thought it was going to be." And so Really, the most common side effects that we counsel patients about is that there can be some mild nausea on the day of treatment. That's actually usually from the amino acid infusion. That's different, actually, than what's given with the lutetium PSMA. They don't actually need the amino acid infusion for that. So, our patients with NETs receive it's a 5-hour infusion of amino acids. We give an anti-nausea medicine prior to that to try to prevent nausea. The purpose for giving the amino acids is to help protect the kidneys from absorbing the radiation dose. That nausea is either doesn't happen or is very minimal. Another side effect can be fatigue. Fatigue is usually cumulative. Most patients feel well after the first or second cycle, but by cycles 3 or 4, they're feeling more fatigued. And then lastly, we monitor blood count. So patients can get lowering of red blood cells, white blood cells, and platelets. It is usually minimal and it usually recovers. And in terms of the radiation safety, most institutions like ours, we have a frequently asked questions tip sheet on radiation safety. We co-developed that with our radiation safety team. It includes things like, so we advise our patients for 3 days that they should not sleep with their partner, really limit close contact for 3 days. There are toileting recommendations in terms of, do you have a single bathroom in your home? And if so, how do you wipe the toilet and double flush and things like that. We also have recommendations for patients if they need to use any incontinence products. So we dive into those details, and I think that's really important to partner with your medical team on that if you have questions. We've now had lutetium dotatate FDA approved for 6 years. So I think that we've done a better job at education. I think the public is more aware. As you may know, patients with NETs are very active and involved in lots of patient support groups and blogs, and so they educate each other. And so I think that understanding and awareness has gotten better. I think there's more of a perceived fear than an actual fear around this form of radiation. It's actually incredibly safe. So just to kind of back up, the lutetium dotatate beta particle only travels millimeters. So it really is very safe and it decays very quickly. So that's why after just a few days, patients can really go back to their normal activities. So I'd like to just also mention that the field of evaluating radioligand therapy, so that's the category under which lutetium dotatate falls, is really busy. So we have all these clinical trials that are happening in the field. Some are looking at different agents, so that's lutetium editriotide. We are also starting to see active agent compared to active agent, which is really exciting. So this alliance trial that's being led by Doctors Habde and Suarez is examining well-differentiated grade 1 to 3 metastatic pancreatic NETs in the first-line setting for symptomatic and some in the second-line setting, lutetium dotatate versus capecitabine temozolomide, a really practical, important study. And we have a new agent and a new sort of particle of radiation, so actinium-225 dotatate versus investigator choice therapy is the Action 1 trial. This is for patients after they've had 4 cycles of lutetium dotatate and at time of progression considering actinium-225 dotatate. And this is an alpha therapy. So lutetium dotatate secretes a beta particle and actinium-225 secretes an alpha particle that in theory is higher energy and that particle travels a shorter distance. So the theory is that it may be more effective and less toxic. And then lastly, I'd like to highlight, this is actually a study being led by my colleague, Dr. Singh and Dr. Aman Chauhan. And this is looking at, can we retreat patients with lutetium dotatate? So this is following 4 standard doses, and it's giving an additional 2 cycles of lutetium dotatate at time of progression. So a really exciting area of research. So back to this patient. So we really selected lutetium dotatate initially following progression on octreotide because we thought that this was one of our most effective therapies. It both has a long progression-free survival and has the ability about a 20% chance of shrinkage. So the patient did really well for about 2.5 years. And at that point, the MRI abdomen pelvis showed an increase in the size and number of liver lesions. The gallium-68 dotatate PET CT, which you can see on the right, confirmed progression with increase in size and number of liver lesions, new pulmonary omental lesions, and bone lesions. So that figure on the left was the gallium dotatate PET CT right after she completed lutetium dotatate. And then the one on the right is 2.5 years later. So multiple treatment options have been presented and discussed with this patient, including additional ludotate, everolimus, cabozantinib in clinical trials, and the patient's currently being evaluated for the actinium-225 dotatate clinical trial entitled Action 1. All right, so we're going to move on to case 2. So shifting gears a little bit. So this is a 61-year-old man with a functional metastatic, well-differentiated WHO grade 3 NET of the pancreas with liver, bone, and lymph node metastases. And he has had progression after multiple lines of therapy. So he has a lengthy history. I'm just going to briefly outline without a lot of detail, but he has had carboplatin etoposide. He had that as his first treatment, had that for about 9 months, and it was stopped due to progression. Had palliative radiation to his lumbar spine, to a painful bone lesion, capecitabine temozolomide, and had that really off and on for 1.5 years. And the starts and stops were really due to episodes of neutropenia and thrombocytopenia. The thrombocytopenia was so profound that we ended up taking him for a splenectomy, and then ultimately he had progression, and we deemed the capecitabine temozolomide not effective. He then went on to get lutetium dotatate for 4 cycles. He had more palliative radiation to a symptomatic femur lesion. His past medical history is significant for migraine, the thrombocytopenia I'd mentioned before, hypertension, and he had that splenectomy for hypersplenism and thrombocytopenia. He's married, has a strong social support system, is a never smoker, and drinks 1 drink per week. His current meds include famotidine, gabapentin, valsartan, and denosumab. The denosumab is for his bone lesions. So you can see here, this is his gallium-68 dotatate PET CT at the time that I was seeing him. So what we're going to be talking about is what happens after somebody has had multiple lines of therapy. So a recent CT scan demonstrated progression in the liver and adrenal metastases about 6 months after completion of ludotate. So that was the most recent systemic therapy that he had. So we can see here, this is a multiphasic CT scan. His lesions are actually best seen on venous phase. And you can see these like very little tiny scattered liver lesions we're seeing them more numerous in that bottom panel compared to the top panel. So this patient has had carboplatin etoposide, cape-tem, lutetium dotatate. So what's the most appropriate next step? And I'll remind you, he has a pancreatic NET. So many of you may have heard we had results presented from the large CABINET trial. This was a phase 3 study of cabozantinib versus placebo, led by Dr. Jennifer Chan. This was a randomized study, 2-to-1 of cabozantinib 60 milligrams versus placebo, and had 2 parallel cohorts, a pancreatic NET cohort and a non-pancreatic NET cohort. Primary endpoint was progression-free survival. And this is sort of the key takeaway slide for the primary endpoint. So on the left figure, we see extrapancreatic NET median progression-free survival favored the cabozantinib arm with a median PFS of 8.3 months for cabo versus 3.2 months for placebo. And then in the pancreatic NET cohort, we similarly saw a longer median PFS for cabo. So cabozantinib median PFS was 11.4 months versus placebo, which was 3 months. In both cohorts, this was a statistically significant difference for median PFS. I'd like to just also mention in the upper right corner of this slide, the targets that cabozantinib hits. It's c-MET, VEGFR2, AXL, and RET. This is, I would say, it hits more targets than sunitinib. That's the only other tyrosine kinase inhibitor approved for NETs, and that's specifically only for pancreatic NETs. The response rates are also important to call out for this trial. So again, on the left, we see response rates for extrapancreatic NETs. The response rate is quite low. It's at 4%, compared to the pancreatic NET cohort, where we see a response rate of 18%. And so this is higher than we've seen. So the sunitinib response rate was also in the single digits. So I think that what we're seeing is that with cabozantinib hitting more targets, we're seeing a higher response rate, specifically in the pancreatic NET cohort. This is a slide that demonstrates the adverse events. So we are seeing the adverse events that we would expect with a tyrosine kinase inhibitor that hits those targets. So specifically hypertension, and then we're also seeing fatigue and diarrhea. What's interesting is that we're seeing slightly different adverse events in the extrapancreatic NET versus the pancreatic NET cohort. So in PNETs, in addition to hypertension and fatigue, we're also seeing more hyperglycemia, a thromboembolic event, and hand-foot syndrome. So I'd like to point out that the study of TKIs is not new in the field of neuroendocrine tumors. We've had lots of inquiry in this space. So there was a study evaluating pazopanib that demonstrated a benefit specifically in advanced small bowel nets, favoring kind of the pazopanib arm. However, this did not move forward for a phase 3 study due to a kind of strategic company decision. Surufatinib has recently been studied in 2 large pancreatic and extrapancreatic NET studies. And however, this was a study performed only in China, so the FDA denied approval, and the company is pursuing additional studies to examine this in a broader kind of multinational study. Axitinib also demonstrates efficacy. This was evaluated in extrapancreatic NETs, demonstrating a PFS benefit that was not statistically significant, but I think the takeaway from this study is that we saw a high response rate. And then lastly, lenvatinib has also been studied in a smaller clinical trial where we're also seeing higher response rates. This was not randomized. So I think really just to give you a big sense of the landscape, what we're excited about the cabozantinib study is that this finally demonstrates prospectively benefit in the small bowel NET population. So back to our case, this patient was started on cabozantinib, 40 milligrams PO daily. I'll note that I do not start at the 60 milligram dose. I think that can be a really difficult dose for these patients, so I usually start at 40. He is tolerating the treatment reasonably well with mild side effects, including some loose stools, but not requiring antidiarrheals, some occasional mouth sores and dry skin on his hands and feet. And his first new interval imaging is still pending, so I don't have that to show you. All right. Lastly, I don't have a case for this, but I do want to just highlight another recent FDA approval and discovery in NETs. So belzutifan for von Hippel-Lindau disease was evaluated in a study, kind of a broader study, but this is specifically looking at the pancreatic lesion population of the phase 2 LIGHT-SPARK 004 study. And so belzutifan, again, is being evaluated in this population. The overall trial looked at both pancreatic lesions that weren't necessarily neuroendocrine tumors and also at pancreatic NETs. And you can see the numbers are relatively low, specifically for PNETs. There were only 22 patients evaluated or that were in this cohort. But what we see is actually very encouraging results. And so this is the waterfall plot demonstrating best response. And we can see that in the table on the right, specifically looking at that red box of pancreatic NETs, that the overall response rate was 91%. So the large majority of these patients really had a robust response to treatment. These are just some examples that were pulled from the publication. And what we can see is in this single patient, moving from A to week 43 to week 202 is really disappearance of this pancreatic lesion. All right, so I'd like to go back to this adaptation of the NCCN guidelines. And what's really exciting in 2024 is that we really are likely to have two new options for patients. So these have not yet been FDA approved, but I will mention also, in addition to the cabozantinib that I reviewed with you, the NETTER-2 clinical trial was a positive study looking at first-line lutetium dotatate for grade 2 and grade 3. And my colleague, Dr. Singh, will be talking about that more. But I just want to leave the audience with this. I think that what I find is that these advances in NETs have come very quickly over the last 10 to 15 years. It's very hopeful. I think the confusion still is in that we don't know the optimal sequence of therapy. So it really requires tailoring therapy for every patient. And so I'd like to end on that, is really just thinking about how do we select these treatments when we don't have a proven optimal sequence. And it's really a balancing act of patient characteristics, treatment outcomes. So what's the goal? Is our goal stabilization, or is our goal to really shrink the tumor? And as I'd mentioned, we have few agents that actually yield tumor shrinkage. What are the side effects? Are they minimal or moderate? And really, how do we think about that in the context of our patients' medical comorbidities? So, as we think about the categories of therapy that we have available for our patients, so peptide receptor radionuclide therapy, also called radioligand therapy, somatostatin analogs, targeted therapies, and cytotoxic chemotherapy, each of these have different kind of treatment outcomes, whether that's moderate response for peptide receptor radionuclide therapy, stability for SSAs, stability for targeted therapies, and cytotoxic chemotherapies, specifically for pancreatic NETs, often yield the highest response rates. And most of these are reasonably well tolerated, specifically PRRT and somatostatin analogs. As we move to the right of the screen, we do get more side effects with our targeted therapies and cytotoxic therapies. So it's really looking at the patient in front of you and tailoring those decisions to your treatment outcomes and the side effects.